we got 7 wonderful and very articulate essays, and we were so impressed by the voices and the passion behind them that we could see that in these essays we were seeing the next generation of leaders. So what we wanted to do was use that as a platform to start a conversation and empower those voices by teaming them up with mentors, clinical leaders, but also making those voices available and accessible to leaders in government. So I just wanted to thank all of our panelists for giving up their time. Most of them have actually not had a holiday at all during this break because they've been working very hard fighting an ongoing crisis. I want to thank all of the attendees, including many committee members from RACS all over the country, passionate about sustainability. And most importantly, I want to thank the stars of today, our 3 student speakers who need to be congratulated because they've just commenced internship. Just to start off with a little bit of housekeeping, this webinar is being recorded. So if you're not speaking or you're not a panelist, could you please turn your video and your audio off? If you have any questions, so what we'll do is we'll do each talk and we'll stop for questions after the talk. And if there's any questions that any of the attendees have, if you could please put that onto the chat function. If we, by any chance, run out of time to ask those questions, we'll definitely be actioning them offline and starting conversations. So with that, I'd just like to start off by introducing our panelists. To begin with, we have Susan Pearce. Susan, who is running in between meetings just at the moment, is the Deputy Secretary of Patient Experience and System Performance Division. She is the head of SHIOC, but to put it in short, she essentially has oversight of the front end of service delivery and system management all across New South Wales, and she looks after surgery. I last spoke to Susan just before Christmas when she was in lockdown, and the fact that she's managed to keep our state safe whilst being in lockdown is a real testament to her leadership, and we really value her time that she's giving up today. Then we have Jean-Fred, who the reason we delayed our start, we were just having some technical issues getting him online, but we're going to keep working on that. Jean-Fred's the CEO.
I'm here.
Oh, fantastic! Yes.
I'm here, Pearce. And thanks for adding to solving the issues.
Awesome, awesome. I'm so glad that you made it online. So Jean-Fred is the CEO of the Agency of Clinical Innovation, and prior to that, he was the CEO of the Bureau of Health Information. Jean-Fred has shared with me that he had a passion for surgery at one stage, but the passion for public health called to him, through which he then did a PhD, and I really admire him for the fact, the way he's been able to not only lead, but give his research such impact in health. So we're really grateful that he's been able to give up his time. And by the way, he too has been in lockdown, so I know that he's not had a holiday. Next we have Carrie Marr, who also has not had a holiday. She's been working through. She is the CEO of the Clinical Excellence Commission, and essentially she oversees apart from setting standards of excellence and setting standards right now in this crisis, Carrie is also a Scotswoman and as such has a keen nose for value. So just as a heads up to all of our speakers that you can't pull a shifty off Carrie. She's a wonderful leader, and she's joined us on many of our events. So we're really grateful for her time. Diane Watson is the CEO of the Bureau of Health Information, and essentially she's the oracle of the data. As she uses big data to drive decisions on healthcare nationally and locally. And I think all of us can see the fact that we have these 4 brains on this panel is such a, it's so valuable to the discussions that's going to follow. So to move on, the stars of the show. First, we have Dr. Imogen Hines, who's currently an intern at Walker Base. I really acknowledge the mentors who have helped them as well. So Bridget Clancy was Imogen's mentor. Imogen's essay is on workforce sustainability with a focus on rural workforce. Bridget's the chair of the rural section of RACS, and she's also a dear ENT colleague in country Victoria, and so we're grateful for her time. Next doctor is Linna Huang, who's currently an intern at Westmead Hospital. Linna's essay is on climate change and surgery. The first paragraph of the essay still haunts me today, which was an image of an intern, of a student walking up to theatre with a keep cup and leaving theatre with more rubbish than she weighs, because that, like many of us, represents what we do. Linna, we are really grateful for Linna's mentors. Firstly, Ken Loy, who's been our most recent chair, my immediate predecessor, but Ken, who's been an amazing leader, is also working on the environmental sustainability group of RACS. Not only that, RACS is very collaborative with other colleges, and in New South Wales we had the advantage of having Roger Harris, who's an intensivist at North Shore and the Sand, but he has an immense amount of experience and knowledge in this matter, in this subject matter, having founded a global healthcare community on climate change. So Roger and Ken have both mentored Linna. Lastly, we have Gareth Couch. Gareth was a student at RPA and is currently an intern at Royal North Shore. And he is going to be discussing economic sustainability in surgery. His mentor is Dr. Arthur Richardson, who is known to most of us. Arthur is a past chair of RACS New South Wales, but he's currently the chair of the Surgical Services Task Force of the ACR, and we all know how passionate he is about this subject matter. So without further ado, we'll just start off with Imogen's talk. The speakers have been very tech savvy and handed us their talks beforehand. So we'll just start that off. And what we'll do is after each talk, we'll stop for questions from our panelists, and for the attendees, if they have any questions or comments, if they could please put it, as I said, on the chat function. Thanks, Alan.
Hello, my name is Imogen Hines and I've just started work as a junior medical officer at Wagga Wagga Base Hospital in the New South Wales Arena. I have an interest in orthopaedics and rural surgery, and subsequently today I'll be talking about the generation of a sustainable surgical workforce. Looking at the big picture, Australians living in rural and remote areas have substantially poorer health outcomes than their metropolitan counterparts. The rate of preventable death is 2 to 3 times higher, and the life expectancy 10 to 15 years shorter. Much of these disparities are accounted for by poorer access to health services, delaying diagnosis and treatment. Our current health workforce is structured in a way that does not provide optimum care to these Australians. Intuitively, geographical distancing should result in a greater number of doctors as a proportion of the population in rural and remote areas, yet the opposite is true. The full-time equivalent rate of specialists declines with increasing remoteness. Although 29% of the Australian population live in regional areas, just 15% of surgeons work exclusively in these areas. And of the 15% who work in regional areas in addition to their metro base, it's largely outreach work completed just once a month. Nearly half of all new rural surgeons are international medical graduates, and this is the direct result of the Australian training pathway failing to keep up with workforce needs. It's easy to think that rural patients can travel to the city for surgery if they need it. Therefore, we don't need as many surgeons in rural areas. Unfortunately, this approach is paternalistic and it doesn't really consider the values of an individual patient. The research shows that rural patients prefer to have a local surgical service, and they're even willing to accept a significantly increased risk of complication to do so. road or air and were thus reliant on the services available in their own region. In addition to this, many rural and regional patients will forego treatment if it involves travelling too far from home, especially those who are palliative, for whom creature comforts, family, and access to primary carers are valued far more highly than medical procedures. To deny these patients the opportunity to have their quality of life improved is a great injustice. There are surgical subspecialties that do not have the population needs to be based in more than 1 or 2 hospitals per state, and that's okay. What we want is a surgical workforce that is sufficient in number and distributed appropriately to meet population needs so that the patients have fair and reasonable waiting times, regardless of their postcode or socioeconomic status. The workforce statistics I quoted earlier have remained fairly constant for many years, despite repeated efforts to increase the number of rural surgeons, the most notable attempt occurring in 2007. In 2007, a metaphorical earthquake struck the Australian medical training system. Changes to health policy and funding led to a sudden increase in the number of medical schools and students. The ripple effect of this seismic policy activity is what is now known as the medical student tsunami. The hope being that the subsequent tidal wave of doctors would wash over the cities and flow down the rivers into regional Australia. Instead, what has occurred is a stagnant pool of junior doctors existing in a medical training system that doesn't have the capacity to soak them up. The end result is doctors spending countless years waiting to get onto surgical training programs, whilst patients continue to wait countless months for surgical services. In line with the current climate, we propose a 3-pronged approach to correcting the surgical workforce maldistribution. These 3 steps are: 1, meeting population needs through appropriate trainee numbers; 2, attracting and selecting applicants with a pre-existing rural interest; and 3, generating and or maintaining a rural interest amongst current set trainees and surgeons. And for those not familiar with the lingo, I'm going to be using the term SET quite a bit from here on in. SET is the term used to describe surgical education and training in Australia, with SET trainees graduating as fellows of the college. Perhaps the most simple of all the solutions, it is impossible to have a sufficient number of surgeons to meet population needs unless we are training a sufficient number of surgeons. As it currently stands, training numbers are principally dictated by terms beyond population need, such as funding, access to senior supervising surgeons, and the availability of jobs for set trainees. This has resulted in a fragmented system where some surgical colleges are producing an excess of fellows who struggle to find employment, whilst other specialties are experiencing a stagnation or a decline in numbers. In 2018, just 1 applicant was accepted into paediatric surgical training in Australia, and none were in 2019, despite a nationwide shortage of paediatric surgeons. We need to make sure that training numbers are not too low, because this won't meet population need. Conversely, and counterintuitively, we also need to make sure that training numbers are not too high. The idea of the medical student tsunami was to flood the system such that there are more doctors than available metropolitan jobs, and the overflow are forced rurally in order to gain employment. The downside of this method is that rural surgical positions can be perceived as inferior and a sign of failing to have the caliber of a metropolitan surgeon. When one considers that surgeons are an inherently high achieving group who have excelled within a competitive career, positioning rural surgery as inferior can create a deterrent. Further to this, rural populations deserve better than to be perceived as a subclass served only by those who are unable to get a job anywhere else. In order to match trainee numbers with population need, we firstly require accurate predictions of these needs that take into account the population, the proportion of surgeons nearing retirement age, as well as the surgical services that should be available in a region and not just what currently exists. I do believe we have quite good data on that. And once we've got that data, we can decide how many trainees are needed. We then need to assure that their training places are appropriately funded and that hospitals are staffed and trained accordingly to be able to take on an additional number of trainees. By the time a doctor reaches the point of applying to surgical training, a genuine rural interest will have declared itself. evidence through the decision to train and work at a rural hospital, involvement in rural health advocacy and defence, or research. Currently, some surgical factions incorporate rural experience into the CV component of the application, and this is a really positive first step. Unfortunately, for most of the colleges, the current criteria consists of 12 months of rural employment from postgraduate year 3 onwards. And this is easily manipulated. So looking beyond or perhaps behind this to consider the JMO and medical student years, in addition to other rural activities such as committee involvement or research, is another way of elucidating rural interest and reducing the potential for manipulation of an egalitarian system. I do want to note that rural background, i.e. where somebody grew up as a child, has limited efficacy beyond selection into medical school. From that point onwards, there are far more efficacious tools to screen for rural interest. An alternative and novel solution is to have a quota of rural training positions with a separate selection process, in addition to bonding those successful applicants to a rural employment for a certain period post-fellowship. Bonding at a medical student level is considered an unpopular solution due to change in circumstance. However, in this situation, we're talking about competent adults with a full understanding of the surgical training pathway and a demonstrated pre-existing interest in rural surgery. The bonding process would merely be an additional step in preventing this rural stream from manipulation. Greater emphasis needs to be placed in supporting rural doctors to become surgeons through access to surgical education, professional development, and research opportunities. Rural junior doctors face greater financial and logistical hurdles in attending conferences and completing courses and exams. In an already competitive field, for some, this could be the straw that breaks the camel's back. Providing rural doctors with additional conference leave to accommodate for increased travel time, as well as grants and scholarships to mitigate the cost of accommodation and travel, can abrogate this barrier. Attracting and selecting trainees with a genuine rural interest is just the first step on their journey into rural surgery. This interest must be maintained for the entirety of surgical training and further interest generated amongst those with a metropolitan focus. Rural rotations form a key component of attracting trainees to rural surgery. For applicants who are rurally minded, the opportunity to complete the majority of their training in a rural area maintains this interest and facilitates the formation of professional and personal connections in specific rural and regional communities. It is essential that trainees with a metropolitan interest have an enjoyable experience during rural secondments and are supported both professionally and socially throughout this time. One of the greatest determinants of future rural practice is a positive rural experience, and one of the greatest deterrents is a negative one. Anecdotally, many trainees perceive a rural secondment as a burden that must be overcome in order to exit the program. Conversely, a rural secondment should really act as a sales pitch for rural surgery, proselytizing the joys of rural living in order to attract trainees to rural practice. There are significant barriers to rural practice which result in recent fellows electing to bide their time awaiting a metropolitan consultant's position or working exclusively in private practice. Extensive research has been conducted into this phenomenon across all facets of medicine. Generally, the largest barriers to rural practice are social and professional isolation, especially if a surgeon has a partner that is unable to work rurally. Amongst surgeons, specific barriers include a greater on-call load, a lack of tertiary hospital support, and a perception of rural inferiority. Subsequently, creating a sustainable surgical workforce involves overcoming these barriers. The first step is increasing remuneration to generate a financial incentive, in addition to mediating some of the costs of working rurally, such as higher medical indemnity insurance rates, increased childcare costs or boarding school fees for dependents, and a reduction in employment opportunities for a non-medical partner. Some regional hospitals in New South Wales have successfully solved the issue of the greater on-call load through incorporating visiting medical officers and locums into their on-call schedule. For example, a desirable on-call roster for acute surgery may be 1 week in 8. In a town where there's only need for 4 permanently based general surgeons, hiring 4 visiting medical officers to work the remaining 4 of the 8 weeks can accommodate for this. This should be a priority in hospitals where consultants are already reporting burnout and on-call fatigue. However, in order to achieve this, we do need to be training a sufficient number of surgeons such that metropolitan surgeons are also available to work those remaining weeks. Another deterrent to rural surgery is the lack of stability throughout the training pathway. It's necessary for trainees to rotate through hospitals in order to have a diverse and high-quality training experience. In rural settings, rotating through hospitals means moving towns, and this comes with a large degree of upheaval. This needs to change, the constant need to change can be reduced by locating fellowship positions that first year after fellowship in rural hospitals that currently have or will have job openings immediately following the completion of the fellowship. Similarly, placing final year STEP trainees in hospitals that have available fellowships would have the same effect in encouraging them to stay at the hospital, especially if they have school-aged children or a partner employed in that region. Frequent location changes are especially challenging for couples who are both undertaking specialty training, as there is limited ability to coordinate locations. This is where the federal government rural training hubs have great potential. Training hub coordinators have access to available training places in all specialties across all hospitals in Australia and can work with these couples to create a training pathway that allows for the greatest location crossover. The most difficult barrier to overcome is undoubtedly the perception of rural inferiority. Unfortunately, changing this perception requires a mammoth cultural change, as it begins with the exposure of medical students to negative attitudes of rural surgeons by senior supervisors. Rather than understanding rural surgeons to be inferior to their metropolitan counterparts, we should encourage all levels of the medical hierarchy to acknowledge the difference between metropolitan, regional, and rural practice, and to appreciate that all surgeons in Australia are exceptionally trained and highly skilled with regards to their respective practice. Surgeons who have completed multiple rural placements across the journey of their career are going to be in the best position to challenge these stereotypes. Australia values the egalitarian nature of its people. However, surgical care in Australia is far from egalitarian. The quality of care a patient receives is highly dependent on their geographical location and socioeconomic status. This is the direct result of a surgical training system that is not receptive to population needs. In order for surgery in Australia to be sustainable, we must utilise the medical student tsunami to water the drought-stricken lands of regional and rural Australia. I'd like to take a moment to acknowledge and thank Dr. Bridget Clancy and Prof. Mukherjee, who have both worked with me on this particular presentation, in addition to RACS for organising this event. And there's some references there in case they interest anyone.
Thank you, Imogen. That was great. I'll just open our panel to questions. So did anyone want to start grilling Imogen on ideas they have? Well, I might start off with a question. Imogen, I think there's problems in the medical, the undergraduate and the postgraduate and the surgical training, and then of course younger fellows as they get into the workforce. I suppose from your perspective as a very recent medical student, one of the things that we've seen from, say, when I went through medical school, then the current generation, is that most medical most programs are now postgraduate, which means that medical students coming through are a little bit older. What do you think? I mean, is that a barrier towards constant relocation? Because once you're a doctor and you're going through the training program, you also need to move a lot. So do you think that perhaps is a barrier, and how do you think that we can address that if it is an issue?
Absolutely, it's definitely a barrier because obviously previously people were finishing medical school when they were 22, 23. It would take them maybe 2 or 3 years to get onto a surgical training program. They'd finish the program by the time they were 30. and then they were able to settle somewhere. Whereas, you know, I was a pretty direct into postgraduate medicine, and I'm still 26 in my first year. For me, you know, things such as having children and all those kinds of things are going to probably, and for most graduates, line up directly with those sort of 5 years of training. And it's really hard when people have children to be able to move and have the flexibility that people used to be able to have. And so it's become more and more important, I think, with rural surgery in particular, to be able to provide people with the opportunity to be based somewhere for a longer period of time, because it is something that definitely incentivizes metropolitan practice. If you have children, and especially if they're in school, you can pick a suburb in Sydney and live there and commute to all different hospitals for all the different rotations, and then maybe do 6 months in the country once and then come back again. Whereas if you're based rurally, people are in positions where they might spend 18 months in Tamworth and then 6 months in Nowra and then 12 months in Newcastle. And the entire time, the expectation is that they and their family are going to up and move. And that definitely creates a barrier to people being interested in rural surgical programs. And after someone spent 5 years in the city in their early 30s, they've probably bought a house, they've probably settled down, they've already organised all their childcare or whatever else is going on in their life. And it's really hard to then up and move to the country after having that degree of stability. So it definitely is a barrier at the moment. And I think having that opportunity to have hubs where people can say, be based in, for example, I'll talk about Wagga because it's what I know. But, you know, if you're based in Wagga, realistically, you could work in Albury or Canberra or Griffith as a general surgeon, and you get exposure to 4 different hospitals, but you're still within a weekly commutable distance where you can go home on weekends and that kind of stuff. And that's definitely one way of mediating the location changes, as well as, you know, having the fellowship positions and the consultants positions in places where people are already based.
Thank you. I suppose the other end of the pie is younger fellows in isolation, and we've had a comment come through about telehealth, the changing sphere. And I just wanted to invite some comments from our panelists as well in how we can, you know, are there any ways into a new decade that we can capitalize on the telehealth networking our metropolitan and rural colleagues in our hospitals, so our younger fellows don't feel isolated?
I'm happy to have a go at that to start with, Paul. Look, I spent the first 10 years of my working life as a registered nurse in Broken Hill. So I do understand what it's like to work in a very rural and remote part of New South Wales. And obviously I'm not a medical officer, but I think the issues are the same. And that is that, you know, there are times where you are seeking and needing advice on particular issues, and that advice can be very challenging to obtain in rural communities, and particularly remote rural communities. So it's quite a frightening thing for young, you know, clinicians, as I was. It's 30 years. It was 30 years on the 7th of January since I started working there. So a few years have gone by since then. I think telehealth, you know, it's certainly not a replacement and shouldn't be viewed as such, but it does have a role in terms of the provision of advice to people who are flying by the seat of their pants in small rural and remote communities in some cases. Obviously, it's a bit different in some of our larger regional rural communities where we've got you know, much more extensive medical support in place. But I do think that it does offer both something for patients in those areas, but also for our staff by way of support. So I think there is a lot more to be done in that space going forward.
Yeah, Jean-Fred, I was just going to ask you as well. I know that one of the things that the ACI is looking into this year is MDTs through the SST, and I was just wondering whether there's a scope also for extending that MDT to include kind of more rural and metropolitan hospital partnerships.
Absolutely, Peo. And I think that virtual communication technologies, have improved so much the capacity of clinicians to support each other at a distance. I mean, not just for, case conversation and case reviews, but also at times also for the actual delivery of complex surgical procedures as well. So certainly that will improve the actual support that clinicians working in rural communities will have going forward. There is one thing I wanted to hear Imogen about, and thank you so much for your presentation. You're really trying to address a very difficult and complex problem. I'm from Canada. I was born in a remote community. My family still lives in that very remote community, and there's a lot of surgical specialties. If they need it and want it, they'll have to drive 12 hours to get it. Now I work in an organization that is really interested in volume outcomes relationships. We know that the more you do certain surgical procedures, quality assurance, safety is improved, etc. And it's almost like a trade-off between individual needs and expectations and systems capacity. And how can we engage with rural communities of clinicians and patients to have that debate, I think, is a question I would ask you, because I really think that in the end, such a dialogue is extremely important to find the right balance. It's interesting when you said that patients would like to have it on site, even at the expense of less safe care, whilst we wouldn't, kind of promote that kind of action. How do you see this from your, clinical community perspective and the broader community perspective?
Yeah, so that's definitely one of the strongest arguments against rural surgery is the caseload argument. I guess it's important to consider that, the role of a surgeon and the role of the health system is to support the community and serve the community. And if the community want local services, and the research shows that they want local services and are willing to accept the risk of that, then, it's really about adapting to their needs and their wants rather than what we as clinicians decide is best. But on top of that, I think one of the things that's really important is that the more that you allow surgery to happen in rural locations, the greater the caseload and subsequently the better the outcomes. And so if you say to a town, no, we don't want you performing upper GI tumor resections, we don't think you have a sufficient caseload to do that, then they might have 3 patients over the course of the year that say, you know what, I'm actually not willing to travel to a metropolitan city for that service. Can I have it done here? And either you haven't got the resources and they don't have it done, or they have it done by a surgeon who's doing it 3 times a year, rather than a surgeon who's doing it once a week. And so it really is absolutely about finding that balance between making sure that, if a patient does want to travel to a city to have it performed by a subspecialist, that's available to them. But that if they don't, or if that's not going to work within their circumstances, that's okay too. Another really important thing to consider is that rural areas have greater proportions of Aboriginal and Torres Strait Islander patients, for whom having services on country is also really, really important, especially if the service has a high sort of mortality risk, because they want to make sure that they're able to, pass away on country. And so that's another thing that we need to consider when we're talking about the funding and access to rural surgical services.
We might just move on to the next talk, because I want to preserve some time at the end to come and discuss all of these, because there'll be common threads. But I just wanted to acknowledge that there is the RACS equity and strategy paper is actually online, and Jenny Chambers, who's one of our counsellors in Port Macquarie, has put up a comment about coordination. So these issues are being looked into, and one aspect of, again, partnerships where clinicians are able to fly in, fly out. There are all of these solutions that can be, that I think everyone's discussing, but we'll come back to discussing this a little bit more, but we'll just move on to Linna's talk, and then again, pause for questions. So Alan, if you can please share screen. Thanks.
Good afternoon, and thank you to Dr. Mukherjee and everyone at RACS New South Wales for the opportunity to present today. My name is Linna, and I'm an intern at Western Hospital.
Last year, I wrote an essay for RACS about my vision for the sustainability in surgery, and I chose to write about the environment. I chose this as it's an incredibly important topic to the general population and especially young doctors, as anthropogenic climate change and its effects present imminent threat to public health. Addressing this issue should be one of our top priorities as health professionals, especially those from resource-intensive fields such as surgery. Our aims should be to reduce the environmental impact of our own sector and advocate for wider climate-positive policies. I wanted to first start by addressing why tackling climate change is important from a health perspective. This is a diagram published by the Lancet Commission into Health and Climate Change in 2015. It is widely referenced in this literature as it describes the end effects of climate change on health. Greenhouse gases lead to climate change through increasing temperatures, rising sea levels, and increases in frequency of extreme weather events. As seen here, through varying vectors including agricultural strain and biodiversity effects, these changes can cause end effects on population health such as malnutrition, cardiovascular and respiratory disease, vector-borne diseases, as well as negative mental health effects. These health issues are all additionally intensified by the social factors on the right that are exacerbated by climate change. As example, over the past 20 years, Australia has experienced one of the greatest increases in fire risk globally, in part due to climate change, and this was particularly highlighted by the last year's bushfire season. This season directly resulted in 417 excess deaths and more than 1.3 thousand asthma presentations, 3.1 thousand hospital admissions for cardiovascular or respiratory conditions. I remind us of this to emphasize that we are already seeing these effects on population health from climate change. The time to act is now. And luckily, the fact that climate change is a population health emergency is well recognised and publicised by doctors and colleges around the country. In my opinion, the healthcare sector and surgery within it, through altering certain practices and using its power through advocacy, can reduce its own effect from climate change and also further affect the wider community's impact on anthropogenic climate change as well. So, how does healthcare affect environmental sustainability? Broadly speaking, through three main ways. Firstly, through greenhouse gas emissions. When talking about climate change, greenhouse gas emissions is the culprit. The sources of greenhouse gas emissions can be direct or indirect. Secondly, I wanted to touch on waste and waste disposal. Though waste in and of itself does not emit greenhouse gases unless incinerated, waste pieces into climate change through the greenhouse emissions it takes to manufacture and then dispose of the waste. And this is on top of the environmental impact of pollution and resource depletion. Thirdly, I wanted to acknowledge the effects of water use and wastewater. Water usages at large volumes can put pressure on the environment through the consumption of precious natural resource and the disruption of environmental ecosystems. It's not one of the points I have focused on in this talk, as it's less directly actionable within the healthcare context. However, it is important to remember when considering sustainability analyses. Let's zoom in on greenhouse gas emissions. This is an overview of Australia's healthcare climate footprint. This data is from a global report on climate footprint of healthcare based on 2014 OECD data. What we can see here is that in Australia, healthcare produces 30 megatons of carbon dioxide equivalents per year, which is equivalent to 6 million passenger vehicles on our roads per year. And according to this same report, Australia is the second highest healthcare emitter per capita in the world, following the US. This pie chart represents the sources of greenhouse gas emissions as per the International Greenhouse Gas Protocol. Scope 1, here in blue, describes the direct emissions from hospitals themselves. This is things including anaesthetic gases used in surgical ORs and emissions from vehicles owned by the health service. Regarding anaesthetic gases, without retrieval system, anaesthetic gases are emitted directly from our hospitals into the atmosphere, and gases such as desflurane, which is the most damaging, and nitrous oxide can be detrimental. Just these two anaesthetic gases were estimated to have caused 5% of carbon emissions from the NHS acute service in 2014. Anaesthetic gases have actually been found at significant levels above the Antarctic Circle. These gases are also much more potent and damaging than carbon dioxide, desflurane having 2,000 times the global warming potential compared to carbon dioxide. This is well described in anaesthetic literature, and these gases are becoming less popular as a result. However, the surgical field can continue to support anaesthetic colleagues in moving towards more sustainable options as they arise, such as sevoflurane and propofol, where appropriate. emissions from electricity that have been directly purchased by the hospital. To provide the surgical context, surgical ORs are 3 to 6 times more energy intensive than other hospital operations, and of that, heating, ventilation, and air conditioning needs comprise of 90 to 99% of OR energy. So how we get our energy and where we purchase it from should be seriously considered. In Australia, we generate 79% of our energy from fossil fuel-based sources, such as coal and gas, which, as many of you already know, are major sources for greenhouse gases. Shifting away from coal and gas should be a fundamental part of any climate positive plan, and how we do so can be planned out with a micro, meso, and macro change approach. On a micro and meso level, healthcare professionals and medical organisations can disengage with services that have not divested from fossil fuel companies, and these things can be companies such as banks and superannuation funds. And healthcare professionals and medical organisations can also move to more energy efficient providers. And this works because money talks. On a higher administrative level, installing solar panels and deriving more energy from sustainable energy sources and providers, and also hiring sustainability officers to optimise energy usage and reducing energy consumption is also very effective. And on an even higher level, we could be using our colleges and medical bodies to support any policies that push for the reduction of fossil fuel burning in Australia, which really should be the ultimate goal. Finally, Scope 3. Scope 3 here in grey describes greenhouse gases derived from indirect emissions, mostly arising from the hospital supply chain. As you can see, Scope 3 is where our largest proportion of our greenhouse emissions are sourced. These kind of emissions arise from the production and transport of medical supplies and pharmaceuticals, as well as the disposal of these materials as well. Of our total emissions, a third arise from outside of Australia within the global supply chain. Let's discuss procurement a little further. Procurement refers to how our healthcare sector receives our resources and involves the entire chain that gets our products into our hands. The two largest procurement emissions relate to our medical instruments and pharmaceuticals. Environmentally speaking, we should be considering procurement options that reduce emissions through the reduction of manufacturing or transport where possible. Much of procurement emissions arise from transporting resources and goods between countries, and thereby are reduced significantly when procurement occurs locally within Australia. Other favourable factors are considering procurement that reduces natural resource impacts, minimises water waste, uses safe materials, and minimises end-of-use effects. By end-of-use effects, I mean considering how the product is used and disposed, how it's handled when disposed, and whether or not it's recyclable, and whether or not it requires waste treatment. To come off topic slightly, aside from environmental concerns, sustainable procurement in healthcare should really also consider social and economic factors. Economic factors include considering financial sustainability and promoting local economic wealth with local procurement. And social factors include considering the well-being and human rights conditions of those in the supply chain. For example, current procurement in Australia likely contributes to modern slavery. Currently, most of Australian surgical instruments are sourced from Sialkot in Pakistan, where child labour and unsafe working conditions are rife. Ultimately, procurement is a major factor in environmental and ethical sustainability, where we need to put our money where our mouths are. All these considerations are large undertakings and can cost money. However, if we are to be serious about reducing our carbon emissions, environmental and ethical procurement should be encouraged at each hospital and ideally incentivized. I've listed some actions here that can help at the individual hospital level, which involves dedicating staff and teams to tackle the issue of sustainability and procurement, and first understanding how procurement occurs at any given facility. Hospitals can start engaging suppliers in advocating for sustainability to group purchasing organisations involved. Interestingly, as of the 1st of January this year, the Modern Slavery Act of New South Wales will come into place, which can assist in ensuring ethical sustainability or transparency at the least. This can be further assisted by creating sustainable procurement policies and building a culture and expectation of sustainable procurement. These are all further outlined in the Sustainable Procurement and Healthcare Guide produced by Healthcare Without Harm. Coming back to the other effects of environmental sustainability, I wanted to talk about waste and waste disposal. I thought this would be particularly pertinent to discuss in relation to surgery, as operating theatres produce 21 to 30% of all hospital waste. This picture here shows the amount of waste produced by one theatre for the removal of a single accessory oracle. So, why should we be aiming to reduce waste and reuse and recycle where safe and reusable? When talking about climate change, what we are really considering is the greenhouse emissions produced. That's why it's important to consider energy savings and greenhouse emissions savings from reduced manufacturing of items when we reduce waste, and the reduction of emissions involved in the transportation of products when we are using less and reusing and recycling more. Other environmental reasons to save waste are to conserve resources involved in producing waste by reducing demand for primary materials, which can involve deforestation, mining, oil drilling, and their associated emissions. We also benefit from conserving landfill space and reducing pollution effects of breakdown products, which is especially important in healthcare, where some of these products are being incinerated and have pollutant capability. Segregating waste properly here can reduce the latter and save unnecessary products from being incinerated. Some strategies to begin tackling waste issues include dedicating staff and team to identify ways that waste can be reduced and look to other hospitals at case studies and implement plan, see, do, act cycles to see what works for each site. I've listed some examples and ideas from around the country on this slide, and more can be found at the website at the bottom of the slide here. I should, however, highlight that some waste reducing methods come at environmental costs in some circumstances and thus require sustainability analyses prior to implementation. To demonstrate this caveat, I'll use the first example I've listed here, which is the sterilisation and reuse of anaesthetic material. I've taken this example from a study by Dr. Forbes McGain, which studied the economic and environmental benefits of this practice, which found that in the UK and US, this practice was economically and environmentally beneficial and saved greenhouse gas emissions. However, when this was studied using Australian models at a typical Australian hospital, it found that though it reduced waste and had an economic benefit, it actually produced more greenhouse gas emissions. This is not the only study that has shown something like this. It's also been shown with reusable versus single-use urotoscopy and central venous catheter kits as well. The common theme here being that overseas in the UK, Europe, and US, these methods reduce carbon emissions, but in Australia, this is not the case. And the reason for this is our energy sourcing, which is fossil fuels. The electricity used in Australia to sterilise and reuse equipment was sourced from fossil fuels and hence increased our carbon emissions. I bring us back to this as I want to illustrate how the incredible effect of local level progress and innovation, such as thinking of ways to reduce waste, can be stagnated and made futile by a national reluctance to transition from fossil fuels. I wanted to finish on this quote from the NJA Lancet report on health and climate change I referenced earlier. Continued reluctance to acknowledge threats posed by climate change at the federal level has hindered progress. I want to bring this point across firmly. Today, I have outlined how the healthcare sector can improve environmental sustainability, but all of this must be done in conjunction with pressure and advocacy to transition from fossil fuels. Medical bodies and colleges have the power to advocate for climate positive policies at local, state, and federal levels, and should do so whenever possible. To not do so, in my opinion, is to be pruning a plant whose root is already rotten. From an Australian junior doctor's perspective, our nation is not doing enough and not moving fast enough. On an issue that affects patients, affects public health, healthcare professionals and bodies need to continually reflect on their own practices and mobilise advocacy on this front. This is especially meaningful from health professionals from resource-intensive fields such as surgery. Thank you for your time today, and I wanted to give special thanks to Dr. Mukherjee, Dr. Loy, and Dr. Harris for providing me with this opportunity and supporting me with this process. I've touched some hospital resources here. Thank you very much.
Wow. Thank you. That was amazing. And you know, on the back of all of this, the amount of waste that we've increased due to the pandemic with our PPE protocols has probably just added fire to the whole discussion. So yeah, just with that, I'd like to open up for questions. I know that both Ken and David Fletcher, who is the chair of our Environmental Sustainability Committee of RACS, have left comments. But I'd just love to engage our panelists in a discussion about where do we start. Susan?
Happy to start. Thank you. That was a very interesting Linna. So well done. And look, I mean, I guess thinking about it at a health system level, given I think the last count we've got something like 163,000 staff in terms of individuals working across the health system. There's a lot of people. There's a lot of big picture ideas there, and being able to influence the use of fossil fuels and so on. I wonder what do you say about what could we do as a health system right now? And I take your point about, money talks, and we could encourage people to buy from sustainable companies and the like. What can we do right now as a health system with that sort of manpower to start to shift the dial on this?
I do bring it back to the kind of the model that Dr. Harris has spoken about extensively, which is the micro, meso, and macro level. And on the health system, I guess we're more talking about the meso level and what we can do from our perspective there. And really, there we can start to think about how we get our energy. So where we get our energy, we can purchase energy through sustainable providers that are more sustainable and don't burn coal, because ultimately what we are talking about with climate change is the release of carbon emissions into the air, which does affect the end health effects of the population. So I really do it really does come back to fossil fuel burning, because that is without changing that, we can't really change much else. And we can't, all else seems kind of, it falls lower on the tier of where we need to act. So I think as a health system, we should be encouraging hospitals to implement their own sustainable sourcing of energy, either, for example, installing solar panels on hospitals and deriving as much energy as we can from there and redirecting it back into the system, and also using money to lower our carbon impact, essentially.
Carrie?
Thanks for that. That was a great presentation. And what I was reflecting on was, if I think of the NHS in the UK, we had targeted sustainability plans over 15 years ago, and every organisation had a target, there was incentives, and that was really helpful because it came in at a macro level. But it's the balance, and I think it's a bit of where Susan was coming from as well, that you can come in here with an intent at a country or a state level, but how do we raise the awareness in every one of our staff that this is something they can influence? So we could reduce we certainly could reduce our fossil fuel imprint, but at the same time, I'm watching staff opening sterile packs every day and using a quarter of what's in the pack. So there's lots of opportunities, so how do we create that awareness in staff that they could be part of that change as individuals, as well as thinking about the macro piece, I
think, sorry, Linna, go.
In that sense, I think there are things obstructing people from using less in sterile packs, and that comes down to kind of policies and admin in a sense. But I think a very useful way to approach it is through a process that's very commonly used in clinical excellence, which is plan, see, do, act cycles, which is that we see a problem, and if we see in surgery that we are only using, as you say, a quarter of the materials in the packs, we can plan a way, and we can see the problem, and then we can kind of plan around it and see and test different ways that we can approach it. For example, we can make packs that have less of the equipment and have backups when we need the rest of the equipment. Once we see, once we identify what equipment's used the most, for example, and then we can trial that and see how that works in the clinical field. And then we can slowly start to make changes within hospitals when we see where we can improve in reducing waste. And that's a good example. Thank you for bringing that up.
Great idea. We need more improvement projects in the sustainability space, is what I'm hearing you say. Great idea.
Jean-Fred?
Yeah, thank you, Linna. Excellent overview of the various factors, and I really love that pie chart that you have that demonstrate the contribution of the direct, indirect, and other sources, because very often we forget that it is also the actual production of healthcare services that is actually generating all of that pollution. And my question to you is there a risk in focusing on, green energy for hospitals and reusable instruments, etc., when in reality we know that potentially there's 30% of healthcare that could be avoided? 50% of medications never get into a patient for various reasons. And therefore, even there at the start, just because we're providing too much services, we're contributing to the environmental impact. So, are we giving ourselves a good conscience by reusing, reusable instruments, whilst in reality we should really attack too much care being provided?
Yeah, I think that's an interesting perspective, and I think more, I guess, a bit of an ethical debate really is like what we should be prioritizing. But I think from a healthcare perspective, it really comes down to population health in the at the end of the day, and what we do, what really affects the larger population in that way. How you would measure that, I'm honestly a bit of a loss for that, but weighing ultimately should come down to population health and how much we're impacting climate change, and through that way impacting population health, and by not providing services seems like a more direct way of not attending to population health. So it's an interesting debate, and I'm not sure I have an answer to that.
And they could probably, synergize. If you interest clinicians with the alternative options, which are green and all that, and at the same time engage in the debate around providing too much care, it could be a real win-win situation.
Diane, did you have any comments or questions?
Yeah, I had some observation actually, and it's both Imogen and Linna. That must start with Linna and maybe go back to Imogen. And that is just sitting here for the last hour or so to see the extent of the talent and the observations that our early career surgeons are making around these big complex issues that will be with us for decades. If I start with Linna, then the observations that I have is we've been part of presentations in the senior executives of New South Wales Health around building design in terms of designing our new hospitals in ways that are energy conscious, can optimize solar use, for example. We participate in presentations where we've seen around the environmental impact of our laundry services and our food services. And there's a lot of activity in that space as well in New South Wales. And so the next step, what I'm thinking of is how do we connect the talent that we see in the fantastic thoughtfulness that you bring to this topic to start to infuse action among our clinicians, going back to Susan's point. If we see it in our infrastructure happening, we see it infrastructure within the hospitals that we're building, and then how do we mobilize the 163,000 staff? And Linna, you don't have to do it for all 163,000, but it's like your networks and then their networks is something that we should think about, Susan, Jean-Frederic, Carrie, and myself, in terms of bringing you close into the system to be able to start to action things. And at the same token, with Imogen, the observations around rural, again, this international issue in countries such as Canada and Australia, geographic distribution has been a problem for decades and will probably continue to be a problem for decades. And we continue to need to chip away at it with the life cycle of physicians as they retire and bringing in new. And I would just add data to that complexity, because I've worked more in Imogen's space than I have with Linna around data. So some of the things that data tell us is, if you follow the life cycle of clinicians, as an example, when we expand our medical schools, they don't all pick the specialties that we want them to. And when they pick the surgical specialties that we want them to, where they go on placements in rural health, then you follow them and then they end up working in Bondi, right? So we can take data to start to test out some of the ideas that you have. One last note on data on physician supply and distribution is that I have done reports in the last number of years that actually show the counter to the typical, which was what you had described, in the sense that there are some surgical areas. And my example, which is true from a couple of years ago, I don't know if it's true today, it was about 4 or 5 years ago, where cancer surgeries for malignant breast, bowel, and lung cancer, the access to surgery is uniform across geography, and so is wait times. And it doesn't mean that that's all surgical areas, but there are areas where we have fixed this. We need to monitor it to make sure that fixing it is sustained over time. So again, just close off my observations actually for both speakers is ways in which we can connect the talent that you are and the talented work that you're presenting to us today, put in a little bit of data to partner around those insights and those observations, and bring you both in closer to our healthcare system, so to engage your talent in a change agenda.
Thank you, Diane. We're just going to up the ante on that talent with Gareth's talk, which is on financial sustainability. So we want to make sure we have at least some time for questions. We might just move on. Thanks, Alan.
Ladies and gentlemen, my name's Gareth, and I'm one of the new interns at Royal North Shore Hospital. I'd like to acknowledge the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respects to elders past and present, and extend that respect to all Aboriginal and Torres Strait Islander people here today. Thank you to Associate Professor Arthur Richardson, my supervisor, and Associate Professor Mukherjee and RACS for setting up this webinar on sustainability, and to talk about what is really a very significant issue for modern surgical practice. It's an issue that has very real implications for how the surgical care we deliver must evolve over the next few years, and what changes we need to make now. It encompasses a large number of diverse domains, including financial, environmental, and human. I'm going to talk more specifically about economic sustainability in my talk today. And in particular, I want to elaborate on what my vision of an economically sustainable surgical system is, how Australia compares to that, and how the Australian system could better align. That vision. So it's useful to start with some definitions so we all begin with the same mental model. When we speak about sustainability, I think there are two main aspects. On one hand, the word sustain implies experiencing an unpleasant extrinsic event, such as sustaining an injury. On the other, it connotes prolonged support in a time of resource scarcity, as in sustenance, or harkening back to the Latin root, to endure. Marrying those two concepts together, I think if something is sustainable, it can endure extrinsic resource pressure it is subjected to without decompensating. So if that's the definition, is the Australian surgical system sustainable? Have we, and will we maintain performance in the face of financial resource scarcity? That's a very difficult question to answer, but I think whilst we do a very good job, without reform, there's evidence to suggest that it won't stay a sustainable system. Nationally, elective surgery waiting lists are growing faster than elective surgery admissions, and individual out-of-pocket expenses are rising on average at 6.2%. That's more than double in a decade. So it's clear that in the current economic climate, we're requiring patients to pay more and more for a surgical system, which is asking them to wait longer and longer. And that suggests to me it's not a sustainable system. Where are those economic pressures on surgery? Put bluntly, care is becoming more expensive. Our patients are becoming older and sicker. They demand more from our surgeons. And we're using toys that are more and more expensive. The Da Vinci robot, for example, costs $1.2 million US. Put this together, and I think Australia is an example of a surgical system where the cracks are beginning to show. Given this bleak picture, I think we have to ask ourselves, if Australia's system is not sustainable, what does an economically sustainable surgical system look like? This is a surprisingly difficult question to answer. Whilst many health systems and surgical systems exist worldwide, there's not one unifying vision of what economic sustainability looks like. So I had a look at the literature and tried to distill down the mechanisms people had suggested to promote economic sustainability. And I've come up with the following 5 principles, which I'd like to go through in more detail with you. Firstly, I believe that sustainable surgical systems evaluate and continually reassess the value of surgical interventions, using those assessments to shape the surgical market. By ensuring surgeons provide high value care, that is to say, care that costs fewer dollars per health outcome, we can treat more patients for the same amount of money. This is not a new idea. Australia has actually really led the world with this by implementation of health technology assessment, or HTA. The diagram on the right is a diagram of our current HTA process, but it's not universal. Importantly, I believe that HTA should be a continuous process throughout an intervention's life cycle. And this is an area that's been identified as a weakness in the most recent reports of our HTA system. The reason for this is that interventions may not always be as cost efficient as they first appeared. The cost-benefit ratio of laparoscopic cholecystectomy was overestimated when it was first introduced in the 1990s due to increased rates of bile duct injury early in the adoption of the procedure and increased rates of cholecystectomy, both of which were unexpected consequences. Surgical devices can't always support the lofty claims their manufacturers purport. Like surgical staplers, which have never been proved to be cost-effective despite cutting theatre time. How should we perform continual value assessment? Well, this surveillance should start with individual surgeons and M&M meetings and audits, but it can be made more efficient with the use of system-wide pooling of information across many hospitals in longitudinal multi-center observational studies, which allow powerful analysis of areas of improvement. The generation of patient and device databases linked to electronic medical health records or electronic case logbooks for trainees may allow the easier collection and pooling of health information to detect emerging surgical issues. Or areas of low-value care, allowing surgeons to adapt. Again, Australia has begun to invest in this. We have the morbidity audit and logbook tool and the National Joint Registry, which have already proved their worth in the ASR hip implant debacle. But it's clear we have a long way to go to develop the infrastructure and legal frameworks to allow us to generate that data. If low-value interventions are found, they should be disincentivized. And this is an area that Australia and many countries have struggled with. This diagram shows how much we fund one low-value surgery, spinal fusion. You can see on this graph the number of spinal fusions being performed in Australia in the public and private sector. And you can see the lines diverge. We're massively over-servicing the private sector patients. And this is in the face of good evidence that fusion for degenerative lower back pain is not effective. More recent data suggests that up to $99 million in New South Wales alone goes into funding low-value healthcare. There are numerous methods to disincentivize economically unsustainable behaviour, from economic disincentives, guidelines, pay for performance measures, stricter penalties, or better feedback to surgeons. We've trialled a few of these in Australia, choosing wisely as one example of a feedback mechanism, but no one's found the perfect tool. It's probably some combination of what we've tried. What is clear, though, is that in an economically sustainable system, we need good ways of clamping down on low value. The second principle of an economically sustainable surgical system is that it has good research practices in place to find ways of improving value. In addition to just disincentivizing low-value behavior, it learns from its mistakes and improves. Such an approach requires a robust research network. So how can surgeons perform good research to improve our outcomes and use of surgical economic resources? Firstly, it requires consistent funding. Australia has struggled with this in recent years. The graph here shows how our funding fluctuates and it's been trending downwards. And similarly, the NHMRC had its lowest success rate ever in 2020 for grants. Funding represents an investment into a financially sustainable surgical system. Return on investment from health research and development in Australia in 2016 was estimated at $3.20 per dollar spent, saving up to 62,000 DALYs by 2050. That's a huge potential financial saving for our surgical system. Secondly, and perhaps more easily changeable, good research requires good research organisation. In addition to lack of funding, there are numerous challenges to research in surgery, like time constraints, a lack of collegiate support, few exemplars or mentors, and absence of a defined training program for academic surgeons. Well-structured surgical research organisations can help solve many of these issues. For example, the centralisation of surgical research into one institute, which is the approach Royal Prince Alfred has taken, gives direction to research efforts, it concentrates academic power into one area, permitting collaboration, and it fosters mentorships for students. Research organisations also give surgeons a more structured way of negotiating with hospitals to set up contracts that incentivise doing research, like 0.5 FTE positions that allow adequate time to pursue academia. This is a much more powerful and sustainable incentive than the publish or perish culture that has dominated for years. Research in economically sustainable surgery must not only employ both historical laboratory and applied research techniques, but also learn from the intellectual gains and innovations of other industries. Surgeons are starting to see the fruits of industry partnerships, particularly in areas such as 3D simulation, where techniques first pioneered in the creation of video games can now be used to train surgeons in virtual reality neurological procedures, saving costly theatre time. The AO Trauma Handbook and the now gold standard osteosynthesis techniques it pioneered was so closely tied with Swiss industry that surgeons literally set up their own industrial firms to make the tools and implants they proposed. Barriers to industry partnership exist in Australia, particularly from a research governance level. One study, though not surgical, showed it took 203 days for a multi-site combined private and public ethics approval to go through. That's too long to have to wait for improvement to happen. Even if we find solutions through our research and development to increase economic sustainability, they do not add value if they're not implemented and delivered to patients. The third aspect of an economically sustainable system is therefore that it rapidly implements the new technologies it discovers to increase value, to innovate itself out of resource scarcity. New technologies have the potential to radically cut costs by either being cheaper themselves, like a cheaper 3D printed implant or screw, or by reducing time in hospital, like synthetic skin for burns. Even if those two examples might seem like blue sky thinking, it's not so long ago that the invention of intramedullary nails for femoral fractures allowed people to mobilize 1 or 2 days after an operation, where they previously spent months in Thomas traction accumulating complications and costs. So obviously, there's a huge potential for new technology to be cheaper and better, and the earlier it's delivered to the coalface, the more savings and value surgeons, the surgical system, and their patients can reap from them. The problem is that many new technologies claim to be cost efficient, like the Da Vinci robot, surgical staplers, but not all of them turn out to be. And that's because preliminary data before market rollout is by definition preclinical or very small numbers, so it's difficult to extrapolate to the whole health system. So how do we avoid the risk of type 1 errors, allowing non-cost efficient things to be licensed, without succumbing to type 2 errors, which prevent all technology from being approved? I think the answer is horizon scanning and evaluation-based implementation. Horizon scanning allows for early identification of promising new technologies and timely development of legal, infrastructure, and training frameworks such that new technologies can be rapidly and safely implemented. This implementation is supported with interim funding and coupled with data collection in the form of registries and regular audits. Introduction of the new technology or technique is structured with appropriate patient consent and involvement. Incentives and legislative approval only continue to be given if long-term data supports the new technique. This approach not only improves patient access, but also allows rapid, effective evaluation of new technology due to sufficient early uptake. Again, to its credit, Australia has led the way with this. For example, endovascular repair for AAA was approved by use of a registry and in partnership with RACS. But I think it's a method that in Australia needs to be used in a more concentrated, structured effort and with more input from lawmakers to allow new tech without precedent, like 3D printing, to be used. A fourth aspect of my vision for economically sustainable surgery is that it embraces models of care that streamline patient interactions. Optimized models of surgical care have significant potential to curb surgical expense and increase value, as they affect numerous patients across an entire surgical service. Many models of care with evidence of cost efficiency aim to decrease time spent by patients in hospital, a key driver of cost. Elective day surgery services and early mobilization programs may achieve this among an elective population, with other benefits such as increased patient satisfaction. Patients who receive emergency surgery similarly may be better served by hospitals with an acute surgical service rather than an on-call roster, waiting for less time to be seen, being discharged earlier, and having a greater likelihood of an operation in hours. Telehealth services avoid patients coming into the hospital completely, and unsurprisingly, have also been shown to be cost-efficient and feasible for surgical follow-up. Role substitution with physiotherapists or allied staff run clinics may take the strain off surgical staff, with attendant increases in value for the surgical system. Waitlist prioritization and increasing the efficiency of waitlists may further increase the sustainability of a health system, and we've seen this within Auburn Hospital. Prompt surgical treatment of the right patients may reduce long-term health resource utilization and and regular audits of waitlists to remove patients requiring low-value surgery increases value whilst shortening the waitlist. Perioperative health optimization in high-risk patients may also reduce the risk of costly complications. Finally, and I think this is something that is less recognised, I believe that economically resource sustainable systems are also sustainable across other resources, including human resources and environmental resources. The staff in a hospital are its most valuable, most expensive resource. In terms of a minute of theatre time, wages account for more than 50% of that time. Surgeons take time and investment to train, so when they burn out, you lose your return on investment. Yumiko Kododo, who became famous for her burnout story, would have taken almost 10 years to train. So in addition to the moral imperative to treat people in a way that encourages them not to burn out, there's also a business imperative. It's only recently we've started looking at this, and the numbers aren't known. However, in the US, physician burnout is estimated to cost up to $6.3 billion. We also have started to learn that some interventions to mental health are cost efficient, like screening for depression among surgical residents. RACS has only just started with its Operate to Respect campaign, but it will be interesting to see if this has an effect on value. Similarly, the cost of our environmental resource use is huge. 20 to 30% of an institute's waste is from the operating theatre. And the cost of disposing this waste across Victoria was close to $17 million last year, and that's set to increase. Reduction in single-use materials like gowns or laparoscopic equipment, changing to alcohol-based scrub wash to safe water, or using LED energy-efficient surgical lights have all been shown to be more cost-efficient, as well as more environmentally sustainable. That's not to mention, I guess, the more existential fact that if there's really no point saving all of this money if the planet's going to burn anyway. By saving on all of our resources, human and environmental, we save on money and make our surgical system more financially sustainable. So to conclude, we stand at a critical time in surgery. The population is becoming older and sicker, the health budget becomes ever strained, and our shortcomings are beginning to hurt patients. The field of surgery must rise to meet this economic resource challenge whilst upholding patient care. That is the goal of sustainable surgery. This appears difficult, but by adopting better continual healthcare assessment, structuring our quality improved practices, rolling out new technologies and streamlining care, whilst also looking after our surgeons and the environment, we can reach an economically sustainable system.
You're muted.
Sorry, I was muting myself. Susan, did you have any comments or questions for Gareth?
Thank you. Look, Gareth, great presentation. It's echoing Diane's comments to the three of you, Imogen, Linna and Gareth. Look, the fact that you're all so very young and thinking about these issues is so impressive, and congratulations to all of you. It does give us old people that have been here for a long time hope that the future of the health system will be in very good hands. Gareth, a couple of comments about your presentation. It's covered a lot of ground. One of the things that I'd like to particularly call out was, and you touched on it at the end there, it really are the human elements of the work that we do in the health system. As you are in it for longer, you will learn, I think, that really that accounts for a lot, and it is a very significant part of everything that we all do, and there is a cost to that if people aren't treated with respect. So I think that is and all that loss of investment in people is a really important issue that we should always, all of us, be aware of. No one's more aware of cost than I am, given that our role in the health system and it's our funding of it and monitoring of it. One point I'd make, and you didn't touch on this in your presentation, but I'd be interested in your views with respect to surgical costs. There are issues around futile surgery that I think we haven't, as a society in Australia, been particularly good at tackling. If you take COVID for an example, there is a very there's no forgiveness in our society for any error or any what people perceive as a shortcoming. And I think, you know, my reflection of expectations, and the community has every right to have very high expectations of its health system, don't get me wrong. But I also think that there is this desperate need in our society to save everyone, and sometimes that's not the right decision on a human level. What are your thoughts around that?
It's very difficult to sway the court of public opinion. I agree with you. I think, I know there have been reports into looking at the COVID pandemic and its impacts on surgical waiting lists. But one of the interesting things about one of the reports that I read was that COVID provides a really unique opportunity to have a very frank conversation with patients about whether the operations that they are waitlisted for are high value interventions or whether they may be better treated. And I mean, if patients have to be on a waiting list for a long time anyway, that may be the time for them to trial conservative therapy and see if that works for them as well. So, you know, COVID specifically, this is a really interesting time. It's a unique opportunity for us to start with that message. But I think it is a message that needs to be had, you know, post-COVID, if that ever exists. And that's a conversation that needs to be had starting from our GPs and working all the way up to our specialists. I know at medical school, one of the classic examples that they have is with antibiotics for otitis media, which I'm sure Associate Professor Mukherjee's very familiar with, but we don't have similar conversations that often about, you know, numbers needed to treat for this operation to occur. Part of that's because we don't have, you know, patient information resources developed for that, and that's something that I'm sure many departments are working on. But it is definitely an area for improvement, I think. Not that I agree with.
Thank you very much. Thank you. Thanks, Pyle.
Thank you, Susan. Now, I know you have to go, and we won't keep the others very long, but I just wanted to give them an opportunity to ask Gareth some questions. So Jean-Frederic, Carrie, Diane, any other comments or questions?
Pale, if I may, well, first, thank you, Gareth. Another excellent presentation. I'm really amazed by the level that all of you have reached in those presentations. And I think that my question to Gareth, but at some point I'd really love Imogen and Linna to be able to reflect on that too, is, you know, what about the synergy between your three perspectives? Because it really looks like it's emerging. And if we increasingly engage young doctors in training and, you know, people that have been there in the system for a while as well, in a conversation where these kinds of sustainability and environmental health and human resourcing, you know, issues are brought together, you know, it could really create some fantastic, you know, system design conversations. And do you think that there's an appetite at the moment in the system? And what would you do to bring more enthusiasm like the one you have for those topics to be discussed increasingly, you know, improving our systems through strong debates and conversations as rich as the ones that you've brought us to today?
Gareth, did you want to start off?
Yeah, I'm happy to. I think, so, okay, engaging junior clinicians, I think, has to start from the very beginning. You know, public health policy has is currently sort of taught in medical school, but perhaps fleetingly, and it's very rarely debated in a way that perhaps we're having now. So I suspect, I would say that reforming medical education so that is perhaps a more of a part of it, of that education, is important. I think the other thing that is interesting is that many doctors are unaware of how expensive many of the interventions are. And that's actually part of the problem that potentially fuels the fire that means that we keep ordering CTs and, you know, things that are not required. And better feedback mechanisms to junior doctors, to surgeons, is going to promote that conversation and perhaps provoke more debate. The question is then, of course, how do you give that feedback? Is it, you know, putting the price packets on you know, every piece of surgical equipment that gets opened, or you know, when you put it on power chart, does a cost come up? that is something that I don't really have a good answer to. I must admit, I suspect, again, some combination of those, but perhaps my other panel members might have better solutions than that.
Imogen and Linna?
Yes, that's an interesting question. You can definitely see the crossover between the interests of the three of us in that, obviously from my little rural lens, health economics and rural health are hugely intertwined, as is climate change, because we know that climate change disproportionately affects rural Australians and disadvantaged Australians. And similarly, the way that we tackle rural health, whether we choose to fly doctors in every day, also impacts the climate. And so these three are all really synergistic things. When it comes to motivating juniors, I think one thing that's interesting to note was when I saw the other two presenters today, I went, oh, I know both of those people. And that's because all three of us are very involved in advocacy and a sort of a passionate bunch. But I think we're a pretty good representation of medical students, or now junior doctors in general, which is that we do have, maybe through selection and through exposure to public health things and organisations such as AMSA that get us involved, they really give us an opportunity to be able to upskill and develop and be able to collaborate. And so I guess, yeah, that's probably the big thing, is that we already have a good group of motivated people, and people become doctors because they care. And so getting us together has been a really wonderful thing. And hopefully there can be more room, I think, in the future, particularly with RACS, to engage the energies of medical students and pre-vocational doctors who are a little bit less cynical and burnt out, and get us kind of doing more stuff. That would be fantastic in the future.
That was the easiest part of this webinar. Didn't have to do any work. Linna?
I do echo everything that Gareth and Imogen have said. I think I do think these topics are actually quite synergistic of each other. They do complement each other. Everything that benefits the environment, many things that benefit the environment do have economic benefits, and we do have studies that show that. They're just, sorry, I'm just getting distracted by the comments. We just need to look at other examples, and we need to study what our actions do, and then we can reflect and act accordingly to this and make adjustments accordingly as well. And I echo Imogen completely. I think young doctors are motivated, junior doctors are motivated to make change, and because that's ultimately what we signed up for. We joined up to help people and benefit the community in such a way. And young doctors, junior doctors will respond to any calls to help. And then even during internship and orientation week this week, I was looking for opportunities to bring up these topics within the hospital, and I was Googling how my particular local health network, and I couldn't really find anything that I could get directly involved in. So making these positions or points of accessibility for junior doctors to voice their opinions will, I think, be very beneficial.
So I think, I can just sort of say that I'm really, really keen to carry this conversation on, and the State Committee will definitely be reaching out to you guys and through your networks, others. And what I'd really like to do with our panelists is work with them to see how we can not just make this as a conversation starter. How do we engage this junior workforce that's so passionate and so talented in affecting the whole pipeline of change, and educating us and helping them continue to lead in the way they have been, but empower them more. So in the interest of time, if our panelists are happy if I keep bugging them with ideas and suggestions, and if our speakers are happy if I keep coming back to them with suggestions, we might leave it there for a Friday afternoon in front of a long weekend. I wish you all a really lovely long weekend, and thank you so much to all of you for your time and your input, and also the comments to everyone on board. So much has been coming through the chat, so thank you everybody.
Thanks, Pia. Thank you.
Thank you.
Thank you so much.
Thanks. Have a great break. Thanks.
Bye.